Good evening, everyone. So, this week we'll be continuing with discussing some topics from leprology, and this week we'll be discussing National Leprosy Eradication Program. Now, there are certain topics in dermatology, or rather in leprology, that that are very dry. Okay, NLEP is one of those topics. Nobody wants to study it. It's a very to the point kind of topic you need to just memorize. But you do get short notes on NLP, and there are instances when questions are asked in Viva. So it's better that we have a certain understanding of what is National Leprosy Eradication Program, so that we can at least write something and answer something whenever we are questioned about NLP. So the main objective of this week's lecture on NLP is to have a quick understanding of what is National Leprosy Eradication Program. Okay, we all know it's a government-run program which is aimed at zero leprosy in India. Okay, so without much further ado, let's not waste much time and we'll start our discussion on National Leprosy Eradication Program. Let's move forward. We know that NLEP is centrally sponsored. That means central government sponsors it, gives money for it. It's a public health program of Government of India, and it comes under National Health Mission (NHM). Theme for World Leprosy Day this year is Unite, Act, and Eliminate. We must unite, act against leprosy, and eliminate leprosy. Okay. Actually, we have eliminated leprosy on a national level. It was eliminated in December 2005, but we need to eliminate even at the zonal level or the state level or in the village level. To the deepest part of the country, we need to eliminate leprosy. We are still, if you're working in a government setup, you know that you are seeing Hansen cases quite frequently. So we need to make sure that the elimination takes place at the deepest levels. So that is the theme of this year's World Leprosy Day: Unite, Act, and Eliminate. So this could be a good Viva question or a good quiz question. Okay, let's move forward. Now, what is the emblem? At least I have been asked once in my Viva that what is the emblem of NLP and what do we mean by the emblem? So, the emblem has a lotus which symbolizes beauty and purity. Okay, we have a shape of the house. So, you can see that this creates a shape of a house. Okay, the fingers, the forefinger and the thumb is creating a shape of the house. And this symbolizes family and inclusiveness of patients with leprosy. We know that leprosy is a highly stigmatizing disorder. That means there is a lot of stigma attached to the disease. And to get rid of this stigma is one of the objectives of NLP. And as leprologists, even we have to make sure that the stigma goes away. So, the inclusiveness of a patient suffering from Hansen disease to be included in a group, to be included in a family, it is symbolized by the shape of the house. Then you have opposing fingers, which shows that leprosy is curable. How? We know that in leprosy, you have muscle wasting in severe grade 2 deformities. You have muscle wasting, and even if you have some kind of neuronal problems, you cannot oppose the fingers. In fact, this is one of the tests, isn't it? We have the grasping test, we have the Foment's grasping test, and we look for the muscle strength while examining a patient of Hansen's disease. If that is regained again, if the action of opposing the fingers is regained again, it symbolizes that leprosy is curable. The action that was lost in the disease is now attained back. And then you have the rising sun in between. You have the rising sun here, which symbolizes hope and optimism regarding the disease. Okay, so this is the NLP emblem. In fact, I think it was asked once in the SR entrance exam to identify the emblem. But now I have shown you the emblem and the various meanings of all the parts of the emblem. Clear? Let's move forward. Now, this is the data that I've taken from a reply which was filed in the Parliament of India. Somebody asked a question that what is the prevalence of leprosy in various states, and it was answered. I've given you the source. You can go and search for the in-depth answer. So I've taken this from the actual answer given by parliamentarians in our country's parliament. So it shows state-wise prevalence, and prevalence is always per 10,000 population. Remember that, okay? So prevalence, we can see that most of the states have less than 1. Chhattisgarh with 2.3 has the highest prevalence per state, as per this reply given in the parliament. Another state, Jharkhand, has 1.4. So these two states have more than 1. Otherwise, you will all see that these are every other state is just decimals. So you can just pause and search for your own state and see what is the prevalence. You might be asked in your exams what is the prevalence of leprosy in that current state, and you can say according to a reply filed in the parliament, this is the prevalence as per that reply. Okay, let's move forward. So two states, Meghalaya and Tripura, have reported zero point 0.0 cases per 10,000 population. That doesn't mean that there was zero cases in the state. That means if you take randomly 10,000 people, none of them will have leprosy. If you take, let's say, 10 lakh patient, you might have one or two cases. But per 10,000 population, the prevalence rate was found to be zero in Meghalaya and Tripura. Mizoram was initially stated to have zero cases, but according to this reply, it's 0.1. So, two states that have zero prevalence is Meghalaya and Tripura. Let's move forward. So, this is just to show that prevalence of leprosy in Delhi is 0.8, and I'm just showing because I live in Delhi. So, this is for my state. Now, there are instances like in Chandigarh, it's 1.4. Why? Because it's a referral center. You have hospitals working as autonomous bodies at national level. These hospitals cater to leprosy patients. So, most of the patients which are working there, they consult that hospital, and we see a large number of leprosy cases in those hospitals. Because of this kind of referral bias, you have high prevalence rate in some areas like Chandigarh, and that is why the prevalence is 1.4. In fact, in states like Maharashtra, you have prevalence more than 1, and that is because they have a huge population. The population cohort is so big that you have a significant amount of handsome cases. Clear? So, and Lakshadweep again has zero prevalence. I'm not included because this is not a state, it's a union territory. State is Meghalaya and Tripura. Otherwise, if you add Lakshadweep to it, then we have three areas with zero prevalence. Let's move forward. The vision of NLEP. Now, these are very important questions. At least in Viva, you can be asked, what is the vision of National Leprosy Eradication Program? Vision is leprosy-free India. It is the what of the program. What is the target? What is the end goal? What is the end point that the target has to achieve? After that target is achieved, the program will be stopped. What is the end point? The end point is leprosy-free India. Zero leprosy in our country. Clear? Mission is how you will achieve that vision. Vision is the end point, and how will you achieve that vision? So you will achieve by providing quality leprosy services free of cost to all sections of society with easy accessibility so that they can easily get the medication. First of all, they can get medication and services free. They can get them easily through integrated healthcare system. That means system is integrated. You have good dialogues between CHC, PHC, sub-center, sub-district level, national level. The dialogue is free flowing so that there's no problem in treating cases of Hansen's. Okay. Including care for disability. So we need to care about disability because of Hansen also. The treatment does not stop at 2 years. We have to take care of disability and rehabilitation also after cure of disease. So vision is what is the endpoint, and mission is how will you reach the endpoint. Clear? Let's move forward. NLEP objectives. Objectives are measurable things. Measurable means how will you measure? What is the quantity to achieve? What is the actual level that you have to achieve? So there are at least 5 objectives of NLEP. The prevalence has to be less than 1 per 10,000 population at sub-national at district level. Remember, at national level, we have achieved less than 1 per 10,000 in December 2005. But we have to make sure that every district has less than 1 per 10,000. And as of 1920 data, 85% of districts have achieved this. We need to make sure it is 100%. The second objective is grade 2 disability less than 1% among new cases at national level. Right now, the grade 2 disability percentage among new cases is 2.4. We need to make it lower, less than 1. Grade 2 disability cases less than 1 per million at national level. Per million population. Okay? Population. So here we are talking about leprosy cases. The denominator is leprosy cases, while in the third objective, the denominator is general population. It is now 1.96, and now we have to decrease it by 1. We should have zero disability among new child cases and zero stigma and discrimination. So the objective to reach is zero. Currently, we lied about this and this, okay, here, but we need to have zero discrimination, clear? Zero stigma and zero disability among new child cases so that they can live their life properly. Clear? Let's move forward. What are the strategies and functional domains? So in previous slide, we have discussed what is the vision of NLEP, what is the mission of NLEP. The mission tells that you have to have a good integrated healthcare system to provide services free of cost to patients and to take care of Hansen's and deformities and disabilities because of Hansen's also. Here, this is the mission. How to achieve that mission? What all things you have to improve in yourself so that you can do all those integrated health system and everything? How to provide services free of cost? How to have easy accessibility to services? So this is what strategies comes into play. Strategies and functional domains. Domains means area, sector in which you have to work. Okay. So we have 8 domains. The first is decentralized integrated leprosy services. So you have to give a decentralized services. What is decentralized? Centralized means everything comes from the central government. Okay. So a person with Hansen's has to go to a central hospital, has to write to central authorities so that they can get services. But decentralized means that even state level, village level can give those services, give those medications. Early detection and complete treatment of all new leprosy cases. Treatment has to be complete and detection has to be as early as possible. Remember, leprosy has a long incubation period. So it gives us a lot of time to diagnose and start treatment, isn't it? So early detection is important. Now, carrying out household contact surveys, we need to survey for contacts. These are those patients who have come into contact with a leprosy patient but have not yet displayed signs of leprosy. They might be infected, they might not be. We need to have a good contact survey to look for those cases. Capacity building of all general health services functionaries. That is, you have to build the capacity, good hospitals, good service centers, good laboratories for testing, good drugs that can be easily, distributed and all. Involvement of ASHA. Remember, APSULS was started 2018-19. APSULS was started. So you have to involve ASHA workers because ASHA workers work at the ground level, at the village level. They know a lot of people in the village. They have better access to those population. They have better access to people who might even not know how to recognize leprosy. So we need to involve ASHA workers so that they can detect early and make sure the treatment is completed. In fact, for every finding of a case of Hansen's, I think I'm not sure, but you can search on the net. Every ASHA workers get about 250 rupees per case if they can get a leprosy case to hospital. Okay, and if the treatment is completed, I am not exactly sure, but if PB leprosy treatment is completed, ASHA worker gets 400, and if multi-bacillary case is treated, ASHA worker gets 600. Okay, roughly. If I get to know about the real data, I'll put it in the comment section. If anybody else can find out, do let me know. Strengthening of disability prevention and medical rehabilitation. Remember, disability prevention is a very important aspect of an LEP and also rehabilitating the patient. IEC, which is information education activities at the community level so that there is self-reporting to PHC. Self-reporting means the patient itself can know the signs of leprosy, find out that there's some problem, and then they can themselves go without help of any other person. They can go to the hospital and say, "Okay, I think I might have leprosy, examine me and do the test. And if I have leprosy, give me the treatment so that I can treat the disorder." We need to reduce the stigma also, stigma regarding leprosy. Intensive monitoring and supervision at health and wellness centers at PHC and CHC level. So the monitoring and supervision, whether the patient has taken treatment, whether the patient is taking treatment, whether the patient has completed treatment, is the disability manageable by prosthetic means, or is there any surgery required? If the patient recovering well, is the patient rehabilitated? They can do their routine work as good as any other normal person. If there's any stigma to the patient, if there's any problems faced by the patient, we need to monitor and supervise it. So these 8 are the strategies and functional domains of NLEP. If you just remember these 8 strategies, you can write pages and pages on NLEP. You can easily expand on each of these headings. Clear? The organization level. This is not important residency level, but at least I think I have been asked in my final MD exam viva that what is the organization of NLEP from top to the groundmost level. Just name what is the one or two organizations working at different levels or people working at different levels. So I thought I'd include this segment here. At center, it starts from the Ministry of Health and Family Welfare, the major cabinet ministry that heads the NLEP program. Ministry of Health and Family Welfare. You have the DGHS, then your Central Leprosy Division, and then all the training institutes. We have Central Leprosy Training and Research Institute. Okay. At state level, you have State Health Society and a State Leprosy Officer. That is important. State Leprosy Officer. At district level, you will have District Leprosy Officer. Easy to remember. You have District Health Society like you had State Health Society, and a District Nucleus Team. District Nucleus Team. Clear? Let's move forward. We have learned about central, state, and district level. Now at block level, you have Rogi Kalyan Samiti. So Rogi Kalyan Samiti is at block level. Just remember that we have the PHC, CHC, and block leprosy officer, or block medical officer. Okay. At PHC level, you have the Rogi Kalyan Samiti of the PHC level or the Panchayati Raj institution. Just remember this name, that P for Panchayati, P for PHC. At PHC level, you have Panchayati Raj institution. At sub-center or health and wellness center, you have the Gram Panchayat and the male and female health worker that looks after Hansen cases or Hansen patients. Okay. And at village level, we have Anganwadi worker and Asha, where Asha plays a very important role to get patients and make sure that they get their proper treatment and they complete their treatment. So village level is managed by Asha. So let's go in reverse order. At village, you have Asha. At sub-center, you have Gram Panchayat and male and female health worker. At PHC level, you have Panchayati Raj Institution and Rogi Kalyan Samiti. At block level, you have Rogi Kalyan Samiti. Okay. At district level, you have District Nucleus Team and District Medical Officer, District Leprosy Officer. And at state level, you have State Leprosy Officer. And at the central level, you have DGHS, you have Central Leprosy Institutes and training centers, and you have Ministry of Health and Family Welfare. Just remember these names, and that is all which was asked in Viva. Let's move forward. Hi. Hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course. You get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break. I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, venereology, and nephrology. That being further said, let's continue with the video. The blister packs. We don't need to go in details in blister packs because it's a very given knowledge at residency level. And right now, as per the WHO thing, there is no PB leprosy pack now. Okay, we give the same drugs, but we give it for 6 months in PB, and we give for 12 months in MB minimum. Okay, we can extend, but what WHO recommends is 6 months and 12 months. Now, one good thing that I wanted to tell you is that from 1st April 2025, the regimen of using all 3 drugs in PB leprosy for 6 months is now to be extended to all the districts of India. So every district will get, every patient coming from every district of India will get 3 drugs in PB leprosy for 6 months and for 12 months in MB leprosy. Okay, this is from 1st April of this year. Any patient who is taking the previous regimen, which is 2 drugs for 6 months and 3 drugs for 12 months, will continue to take those treatment if the treatment was started before 1st April 2025. But now, in every district, the treatment will be 3 drug regimen for both of these cases. Clear? Now, in multiple districts, in fact, you are from Delhi. If you are from Delhi hospitals, we had started giving 3 drug regimen in like about 7 to 8 years ago. So from 7 to 8 years, we have been giving 3 drugs for both of these cases. But now it is to be extended to all the districts. The color of the packs has always been asked in Viva. So in PB leprosy for children, you have the white pack. Sometimes it comes as sky blue also, the sky blue pack. And the orange or yellow pack is the MB leprosy pack for children. Clear? I'm not going into doses because that has already been covered in a previous video on treatment of leprosy and alternative treatments of leprosy. So I'm not going to go into details. But remember, now even in children also, if you're suspecting a PB leprosy case, you actually give the three drug regimen, but you give it for that duration. The doses is less, as evident from the blister pack. Okay, let's move forward. We know that Hansen is treatable if regular treatment is taken by the patient. We tell them, we counsel them that regular treatment is absolutely necessary to treat Hansen, isn't it? Now, what are the aspects under NLEP that ensures that treatment is regularly taken by the patient? It starts with adequate counseling. That means you counsel at the start of the treatment. You tell them about the disease, leprosy is curable, what are the skin lesions, and how to take care of skin lesions and everything. Duration of treatment, 1 year, 6 months, or extended afterwards, also depending on the infectivity status at the end of treatment. Method of taking the drug, oral drugs, all the side effects included with the drugs, when to take the drugs, empty stomach, with food, without food, and all that. The treatment has to be regular. The patient has to be regular in their follow-up visit so they can come and discuss the treatment specifics with you every month and continue the treatment without a stop. All the side effects which are seen with the drugs has to be explained to the patient in detail beforehand, and there has to be self-reporting. There has to be reporting of all the side effects. If the patient suffers any kind of issues with the drugs, those has to be told to the treating doctor so that they can manage it effectively and as early as possible. There has to be regular follow-up of the patient and timely RFT. RFT is release from treatment. Release from treatment. Okay. Now, RFT basically means that MDT is stopped after the treatment. That does not mean that you stop interacting with the patient. Patient might have disabilities because of the Hansen disease. Patient might develop reactions after treatment. Patient might develop a relapse of disease. So we need to keep the patient under follow. In fact, it's a good idea to keep PB cases for 3 years after treatment and 5 years after treatment for MB leprosy, but it's just a very weak guideline. Keep the patient in follow-up like every 6 months or every 3 months or depending on individual cases so that we can look at all the complications that occur after release from treatment, like reactions and relapses and all, and to see whether the patient is able to rehabilitate successfully in the society. Okay. If the patient is absent or not able to take treatment for any reason whatsoever, they need to be contacted immediately to identify reasons, and then corrective measures have to be taken quickly. For example, if a patient cannot come and they might come 2 3 days afterwards, you have to make sure that they get their drug. If they're not able to get drugs properly, maybe contact the regional ASHA workers so that drugs can be delivered to them. There has to be flexibility in MDT delivery. It doesn't mean that if a patient comes regularly for treatment and drug is not available at the hospital. That should not happen. The drug should be available so that the patient can have easy access and the continuation of treatment is maintained. Clear? Let's move forward. Period of discontinuation. Remember that WHO says that PB leprosy, the treatment has to be taken in 6 months but completed in 9 months. That means the treatment has to be taken 6 months continuously, but because of any issues, if the treatment is discontinuous, the entire 6 packs of blister packs, have to be consumed within 9 months, no matter what. The difference is 3 months. Okay, if there is more than 3 month discontinuation in treatment, you restart the treatment for PB leprosy and label the patient as defaulter. The patient is defaulter and I'm starting the treatment again. If the treatment discontinuation is more than 3 months. Similarly, for MB leprosy, if the period of discontinuation is more than 6 months, you restart the treatment. Okay, we know that in MB cases, the treatment is given for 12 months to be completed in 18 months. If the difference is 6 months, if the gap of not taking treatment is more than 6 months, you consider the patient as defaulter and restart the treatment from zero. If there's less than this kind of time duration, then you continue the same line of management because you will be easily able to complete it in 18 months. Let's move forward. Now, what is DPMR activities? DPMR activities is disability prevention and medical rehabilitation. We know that deformities and disabilities occur in Hansen disease. Okay, even after treatment is completed, they may persist, or they may also develop as a consequence of reactions happening after RFT. So these are all the activities under NLEP that aims to counteract the disabilities and deformities. Clear? So first is DPMR activities have to be taken under primary, secondary, and tertiary level. So PHC, CHC, sub-center, sub-district level, everything has at every level, depending on their resources, depending on their adequacy, we need to counter all the disabilities. Detection of complications and referral. Uh, all the government staff at different level of NLEP should know when to refer the patient if the disability is occurring. Let's say a person is having claw deformity which is permanent. You need to refer them for surgical modalities. A person who has developed neuritis, you need to tell them that go and look, go to the nearest hospital and get treatment for it. Assessment of disability status. So we need to have a baseline disability status. Let's say a person has one claw hand and now they have developed claw hand in the other hand also. This will be a significant problem for the patient. You have one hand not working, the other hand which is working is now also a claw hand. So it's better that we know a baseline disability status and we can treat it. And it is also important for data collection also. We need to know what is the baseline people. We know that grade 2 deformity cases or grade 2 disability cases are an important measure for leprosy spread in the country. Okay, so we need to have a data for that. Line list of beneficiaries. So there, a person suffering from disability might receive some kind of benefit from the government. We need to have a list of that. Conduction of activities, persons of disability activities, so that all the activities like knowledge about disabilities, knowledge about deformities, how to take care of the affected limb, how to have knowledge about if the disability is occurring or not, if there's a new form neuritis, if there's new problem occurring, if the older problem is not getting adequate treatment, people should know so they can ask for the treatment. There has to be more of self-reporting in these cases. Self-care demonstration, tell them how to take care of the anesthetic limb or hypostatic limb or the deformed limb or limb with muscular weakness, how to take care of that in their general routine practices. To give kits, now kits may include prosthetics for claw hand or extensors for claw hand, which requires all those springs to stretch those fingers so that some kind of mobility is maintained. And physiotherapy kits, some kind of compressible ball so that you can, train your muscles again. Provision of MCR. I think MCR is multicellular or modified cellular rubber. I'm not entirely sure. It's there in IL book. MCR is special rubber appliances, rubber slippers, which you give for patients who have, hypoesthesia of the feet. So most of the patients of Hansen disease might be indulging in physical labor. So uh, we need to keep their feet protected. So MCR appliances is to be given. If you require, just let me know in the comment section whether you require a separate lecture on what all prosthetics and disability prevention modalities are available apart from surgeries for these patients. Reconstructive surgeries referral. Okay, what is that? Government staff workers should recognize that this patient would benefit a lot from surgical intervention, so that you can refer the patient to trained surgical, centers, so that reconstructive surgeries can be taken. Identify the RCS institutes. You should know where to refer, not just refer for temporal muscle transfer for leg ophthalmos. No, you should know where to refer so that there is no problem for patients to get that level of care. Incentives for RCS. A patient who has undergone surgery or undergoing surgery receives about 12,000 from the government if they want to undergo, not want to, if they're undergoing reconstructive surgery. Initially, this was, I think, about 8,000. Now it has been increased to 12,000. Clear? Social welfare measures. All the NGOs, you have to take care of all the NGOs. In fact, in the website for NLEP, you have a huge list of NGOs associated with NLEP who are working for leprosy care. Okay, special activities and programs, keep the morale high, make provide them provide them with different modalities so that they can train and get rehabilitated again in the society. If they were doing some kind of work which they were not able to do because of Hansen's, have they joined the work back again after treatment, or have they have others, or have they had other sources of income now? Okay, so these kind of things also come under the purview of NLEP, and they are very important aspect of NLEP. Clear? Let's move forward. Nikushth 2.0. We know that Nikushth was an important aspect in 2018 after SLAC, which came in 2017. In 2023, 30th January 2023, which was also the Leprosy Day of that year, Nikushth 2.0 was initiated, which was the second iteration of Nikushth. Okay, so Nikushth 2.0, Kusht means leprosy, Nikushth means no leprosy. Clear? The main aspect of Nikushth is to develop a database of leprosy patients so that they can be properly tracked and follow-up of individual cases can happen. Also to monitor, evaluate, and to modify policies as required. What I want to say is the main aspect of Nikushth is to create an online database of Hansen patients suffering from Hansen. So this could be a very good quiz question or Viva question. The main aspect of Nikushth 2.0 is to create an online database for all patients. Clear? And it has received support from ICMR. So let's move forward. Now, what is global leprosy strategy? Global leprosy strategy is strategy to counteract Hansen's at a global level, at a world level. So initially, from 2016 to 2020, the theme was accelerating towards a leprosy-free world. That means we want a leprosy-free world and we need to accelerate towards it. That means move quickly towards it. That's what acceleration means. After 2020, that means from 2021 to 2030, theme is now towards zero leprosy. At international level, at world level, at global level, we want to achieve zero leprosy by 2030. And this is your global leprosy strategy. What India has done is India has taken a target 3 years prior to it. That means by 2027, zero leprosy in India. And if you remember, this is the vision of NLEP. So what we have done is, since India is a highly endemic country, in fact, roughly about 54% of global leprosy cases come from India. Roughly about half of the cases come from India. So what we have taken is we have taken a very substantial, not setback, substantial level at the target. The time taken to achieve this target, we have taken it 3 years before that. So what we are trying to say is that at international level, we will achieve zero leprosy before 3 years before the global target of 2030. Okay, so if you ask what is the target to achieve zero leprosy, in India it is 2027, at world level is 2030. Clear? Let's move forward. What are the challenges for NLEP? What are the problems NLEP has to face and overcome? So there are a lot of different challenges which have been established in the books. What I've done is I've segregated into different segments so that it becomes easier to remember. The first sector for challenges is agent and disease. That means MLEPRE and leprosy. We know that leprosy has long and variable incubation period. That poses a challenge to NLEP. It is difficult to diagnose subclinical infection. We can easily diagnose if the leprosy has already set in and you have clinical symptoms and signs. But what happens when there are no clinical symptoms and signs? How to diagnose? We don't have reliable tests available as of now. And that makes it difficult for NLEP to go to each and every patient and treat it before the disease sets in. Reactions and nerve damage. We know that reactions and nerve damage can happen even after completion of treatment. Even after completion of successful treatment, you can still have reactions and nerve damage. And that poses challenge to NLEP, how to take care of that. Effective vaccine is not available. We have discussed vaccine in detail in a separate lecture known as vaccines in leprosy. You can go through that. And we know that there is no effective vaccine for leprosy available as of now. And that is another challenge for NLEP. Weak link in establishing transmission chain. Now, what do you mean by that? Remember in COVID, if any person had COVID, we used to ask them who all persons came into contact with you in the last 7 to 10 days, isn't it? So that is known as contact tracing. In leprosy, it is very, very difficult. Because of long incubation period and subclinical infections, patient might come into contact with a lot of people and you cannot have a good contact tracing. So a proper establishment transmission chain doesn't happen and that makes it difficult for NLEP to work. That is another challenge for NLEP. Let's move forward. Program. What are the challenges as per the okay for as far as program the NLEP program is considered? Involvement of health workers after integration. So whenever new health workers come in the program, you need to tell them, you know, train them again. They need to have good motivation to go in the field and look for Hansen cases. Lack of trained manpower. We don't have enough people working in the government sector. We know that there is huge shortage of manpower in different government sectors, including NLEP, and that makes it difficult for NLEP to work. Disability. Now, disability is important. A patient can have disabilities because of reactions occurring after successful treatment. Patient might have persistent of disabilities and difficulties, and all of this can cause problems in rehabilitation of the patient. Okay, so how to tackle that? How to tackle the stigma arising out of leprosy? All of these kind of things happen. How to make sure that the person who has taken successful treatment but has some kind of disability is able to earn livelihoods. These are all challenges of NLEP. Weak monitoring and supervision. Of course, we don't, NLEP has problems in monitoring and supervising treatment, whether they're able to take proper treatment, whether all the data is just not on paper, it is translating into real world scenarios. So that is also another challenge for NLEP. We know that drug resistance causes an issue. We need to have new drugs and regimens. We know that NLEP. We know that before NLEP, dapsone monotherapy was one of the mainstay of leprosy treatment. Patients used to take dapsone for years, for 5 years, more than 5 years, maybe lifelong, only a dapsone. And then the regimen changed to multi-drug therapy, and now we have multi-drug therapy for both PV and MB leprosy. The regimen keeps on changing depending upon the epidemiological data, and we still need newer drugs, newer second line, third line drugs, so that the problem of transmission of leprosy, the problem of resistance in leprosy needs to be taken care of. Also, we need to have good setup to recognize resistance. We need to have laboratory modalities already set up in government sector so that we can analyze and see if the patient is resistant or not. Okay, let's move forward. Now, the third segment is stigma and apathy. Stigma and apathy. We know that leprosy is a highly stigmatizing disorder. Okay, there's a lot of misconceptions about leprosy. We need to tackle that also. There are a lot of hidden cases. Okay, the cases are hidden. For example, if let's say I have developed a patch on my body which has no sensation or decreased sensation, I might not be able to share that properly with my treating physician or treating doctor. There's less voluntary reporting, and because of that, we may not able to recognize leprosy before the disease has set in. Clear? There is lack of research in new tools and intervention. We know there's a lot of problem. We don't have many researchers working in the field of leprosy. We don't have much funding in the field of leprosy for research purposes. We need to have a lot more research to understand the disease properly, so that we can develop new tools to tackle. Okay, there is lack of research for tools. There's reduced resource allocation. For example, not much money is or financial resources are not allocated. Not many manpower dedicated to develop, you know, protocols to analyze or to identify Hansen patients or patients with leprosy, so that you can give good treatment to them. Okay, so many times drugs may not be able to be procured, you know, in adequate amounts. So this kind of resource deficiencies which plague any government institution is also our challenge to NLEP. Clear? Notification from private providers or private practitioners. Now, sometimes a patient with Hansen might come to you in private practice, and you are treating them with a three-drug regimen, which they are buying on their own. They are not taking from government setup, but they are not registered into the NLEP. And if a patient doesn't come for follow-up in private practice, you might not able to, make sure that proper monitoring and surveillance is happening. You will not go into contact tracing. You will not go not give prophylaxis. You may or may not, but mostly we real world scenario we know we may not be able to do it. So this is again a challenge. This kind of challenge can be there for NLEP. Let's move forward. The fourth segment is geography and logistics. That means area, landmass. We know that there are underserved areas and difficult to reach areas. For example, in hilly areas where there would be difficult for people to come to the hospital, or difficult for ASHA workers to go to the people to give them drugs. There can be migrants, people who change their residences quickly from one state to another state. They might not able to get access or get registered very quickly in the new state, and there might be a gap in between the treatments that can happen. We know that lack of research plagues, financial constraints, manpower constraints, motivation constraints also plague the lack of research. We know that drug resistances can happen, and also remember, uh, for any program to work, you need to have resources, be it financial resources or manpower or education or knowledge or motivation. All of the resources are necessary for any program, any government program to work, and it requires a certain set of people who think differently from others to work in a government sector to provide care to leprosy patients. Okay, they might not get the kind of reward normal layman would expect, but they are doing significant work in treating and changing lives for the better for patients who are suffering from leprosy. And that is important. That is a very important aspect of any government program. And there is lacking. We need to recognize that lacking so that we can do work to prevent it and improve it. Okay, let's move forward. So with that, I'll end this week's lecture. I think we have just touched 1 hour, and that's a lot of discussion on NLEP. And if you've gone through this 1 hour lecture, you have all the major aspects of NLEP, and it's enough to have a basic understanding of what is the government program against leprosy, and even write notes if that comes into your exams, or even answer questions in Viva. These are all the thumbnails that we have already done in the lecture series on leprosy. This lecture, the current lecture, is the 15th lecture in the series. And I've tried to make leprosy a bit more interesting. Okay, leprosy is most often the overlooked aspect of DVL. But remember, your degree is DVL, it's dermatology, venereology, and leprology. So you are a leprologist. Okay, diagnosing, managing, treating leprosy is your forte. That no one will take it away from you. Okay, and you know more about leprosy than anyone in the hospital, so it becomes your duty, your prerogative, to diagnose leprosy, and you need to keep your knowledge about leprosy continuously updated. So I request you to go through all of these lectures. We have tried to cover different aspects of leprosy. Newer videos, whenever they are made, they will keep on adding to the playlist on leprosy. Okay, so these are some reading recommendation. I will not go much into that. These are all, government articles, government websites, WHO website. You can copy paste it. It's there in the description link, and read more about the data of different countries. But you just require to go through this presentation. Again, request for membership. Okay, you can become a Ruby member, and Ruby member have access to longer videos with extra content. And if you think that these videos are helpful for you, consider becoming a Sapphire member. Sapphire member have earlier access to videos, few days earlier access to videos. They have access to longer videos again with extra bonus content, extra information. And whenever I need to search for newer topics to tackle, the poll is open to Sapphire members. Even if they put a comment, then they have priority for suggestions. That means quicker reply as soon as possible. First reply is given to Sapphire members, and if any suggestion comes from these 5 members, I include them in my suggestion list. Okay. With that being said, I'll finish this lecture. It's already a long lecture on a very dry, maybe a boring topic, but it's a good topic to listen to when you're walking or driving. Okay. So not much further information. I will stop this lecture now. Adios. Bye bye.